Thank you, Steve. I'd first like to thank ICOS for the opportunity to discuss our clinical approach to cardiovascular toxicity of oral antineoplastics today. Myself, I am a pharmacist at Franciscan Health and Butler University, and I will be presenting with Dr. Vijay Rao, who is our Director of Cardio-Oncology and Heart Failure at Franciscan Health. And also on the call today, we have one of our cardio-oncology nurse practitioners, who will partake in the discussion at the end, and this is Holly Page. Excuse me. So our practice really takes a multidisciplinary approach to the treatment of our cancer patients, and our cardio-oncology practice includes both oncology practitioners as well as cardio practitioners and pharmacy practitioners. And our service really started with IV oncolytics, and we quickly recognized the needs of those receiving the oral therapies, given their increase in use and frequent cardiac issues associated with the therapies. Now, oral treatment of cancer was largely made possible by advances in precision medicine. In the 2015 State of the Union address, the president announced the creation of the Precision Medicine Initiative, which was really a research initiative to advance precision medicine and the treatment of disease. And this came 12 years after the completion of the human genome mapping in 2003. In oncology, oral precision treatment has been in use since the early 2000s, when imatinib came onto the scene and really revolutionized the treatment of AML or CML. Sorry. So oncology is really fortunate in that we have really had a large uptake in the use of precision medicine, and it has led to really, really great advances in the treatment of our patients. We can basically look inside the tumors, see what mutations are present, and then find therapies to target these different mutations and specifically treat that patient's tumor. We're not treating lung cancer anymore, we're treating a specific subset of lung cancer that has a specific mutation, which makes our medications directed to the patient's tumor itself. When you compare this to chemotherapy, you can think of chemotherapy as kind of taking a blindfolded approach or a shotgun approach, where basically the drugs are affecting any of the cells that are doubling, really going after those quickly doubling cells. They're not very specific, they're targeting cells of the GI mucosa, GI tract, the GI mucosa, hair cells, the bone marrow cells. They have many toxicities. Most of these are IV. There are some exceptions that are oral, but for the majority of them, they are IV, and they are cytotoxic, which can be a good thing. We can see a large decrease in the size of tumors when we give these oral or these IV cytotoxic medications, but they do come with many side effects. For our targeted therapies, these take a more directed approach, and they inhibit more specific targets within the cells. A majority of these are oral agents, and they have a mixture of cytostatic and cytotoxic effects. So we may not see a dramatic decrease in the volume of tumor a lot of times in patients, but we do see a stabilization of their disease where we can basically treat it more as a chronic disease as long as they stay as long as they continue to respond to treatment. So when we think about these oral targeted therapies, they really are working on those signaling pathways within the cells. So this here would be representative of a cell surface. This would be a cell surface receptor, and that intracellular signaling pathway, which goes down into the nucleus to drive the cell division and proliferation. Cancers really take advantage of these cell signaling and have mutations which occur to drive the cell proliferation and differentiation. Many of our targeted therapies are kinase inhibitors that are basically preventing the phosphorylation and passing of the signal within the cell down into the nucleus, which stops these aberrant signaling processes within the tumors. So these basically are blocking the processes and signals that help our cancer cells multiply and spread. And we have multiple targets which are available. I've listed a few of them here. They include like the ALK, tyrosine kinase, the BCR-ABL tyrosine kinase, BRAF. There's a multitude of them, and this list is growing every single day, sometimes faster than we can even keep up with. Now, this transition has been in the works for multiple years. You can see here, this is the FDA approvals with the blue line being the total number of drugs, the red line being the number of targeted drugs, and the green line being the number of cytotoxic drugs. And really you see the increase over the last 10 or 15 years in the number of targeted drugs, making up the majority of the total drugs approved, and a significant decrease in the number of cytotoxic drugs. And this this trend continues to this day. You can see here that why this trend is continuing, and as this is the pipeline of the pharmaceutical companies through 2016, where the majority of drugs are targeted therapies as represented by blue, and the majority, a lot of these are these small molecules which are oral targeted therapies, which continue to grow in proportion to the other therapies that are under investigation. One example of where we really made an impact is breast cancer. This is one of the earliest uses of targeted therapy, which kind of shows you the impact that it has made. This is HER2 positive breast cancer. If you look this black line on the graph, this is overall survival versus time. The black line represents those with HER2 negative disease, and the orangish line represents those with HER2 positive disease and how they historically fared. So they pretty much did worse than those with HER2 negative disease. However, when Herceptin or trastuzumab, which is an IV targeted therapy, was developed and instituted in practice, you can see that those patients receiving this drug, which would be the green line, actually fared better than our HER2 negative disease. So we really moved the ball in the treatment of breast cancer. And this has also been the case in multiple other cancers. We've seen similar effects, some even greater than what we see here with HER2 positive breast cancer. Now, these oral therapies have really revolutionized the treatment of multiple malignancies. Currently, there are more than 50 approved by the FDA. They may allow our patients to avoid chemotherapy altogether, which is really good for our patients, and allows us to really treat them within their home. An example of where targeted therapy has really taken over the treatment of a malignancy is with renal cell carcinoma. You can see down here that even in the first line and second line setting, and all different types of patients, whether it be good risk or intermediate or poor risk, our oral therapies like sunitinib, pazopanib, axitinib, cabozantinib are really the mainstay of treatment now in renal cell carcinoma. And really you don't see any other agents besides these targeted agents in the treatment of this malignancy. So it's really taken over. And this is echoed in other malignancies such as multiple myeloma, or not multiple myeloma, melanoma, sorry, excuse me, as well, where these targeted therapies are really taking over the treatment. Despite their advantages, there is a downside to oral targeted therapy, one being adherence. We're moving the administration of these medications from the clinic setting where we have a lot of control over what is happening to the patient's home. We do have delays in starting therapy due to the issues in getting the patient set up for therapy, such as financial issues, getting them patient assistance. Also, these do have limited distribution from specialty pharmacies. There's a lot of drug-drug interactions that we have to take into consideration, as well as monitoring and supportive care, which we're going to focus on cardiac monitoring and supportive care that is necessary. And then always cost is an issue with this, with these medications that can be very costly. So to start with adherence, adherence is very important. This is just to show you patients with CML from the Medicare Part D beneficiaries during the first 180 days. Over time, we really haven't made an impact on adherence. Adherence is defined as taking 80% of the scheduled doses, and really we're at around 30% of the population being non-adherent. Now this does have clinical consequences, as they've shown that in CML specifically, patients who are non-adherent have a significantly higher risk of losing control of their disease. So it is very important that we're educating our patients that they maintain adherence, and that we're not having to make dose reductions or anything else because of other toxicities. One of many of those toxicities being cardiac in nature. Drug-drug interactions can also occur. You can see here that multiple drugs can interact with the metabolism of our oral agents. Drugs that are commonly administered, such as the antibiotics or antifungals to cancer patients, and even our cardiac medications, such as the anti-cholesterol medications, the statins, as well as some other agents such as carvedilol, can also interact with multiple different oral targeted drugs. This doesn't just relate to our FDA approved drugs. We also have to worry about herbal medications and even things like CBD oil, which can interact with the metabolism of multiple medications. It's something that we always have to take into consideration. Lastly, when you think about IV cytotoxic medications and how we give them, we're giving those on a every 3-week basis, or every 2-week basis, or even every 4-week basis, where the patients come in, they receive their 1 to maybe 3 days of chemotherapy. They feel crummy for a week, and then they have time to get better and feel pretty good before they come in to do it all over again. When we're giving these oral medications, a lot of times we're giving them on a daily basis. So these patients are experiencing these adverse effects on a daily basis. You can see here, these are patient-reported symptom scores where they're having a lot of symptoms on a daily basis, and a lot of them, though they're mild, they are continuing to occur. This is the same thing with adverse effects. When you think about the cardiac adverse effects, these patients are getting these medications on a daily basis. So if they are having hypertension, it is, continuing to occur and sometimes worsen throughout therapy. One toxicity that we do have to take into consideration is financial toxicity, especially when we're adding on medications to treat some of the side effects. If you see here up until 2012 where we have data available, these are the per patient per month costs for these oral targeted therapies. The overall cost is in the yellow, and the patient out-of-pocket cost is in blue. The yellow cost in 2012 is around $7,000 a month, while the patient out-of-pocket cost is around $1,000 per month, which can be significant for a majority of our patients, and this has only increased since this time. So these are some things that we need to take into consideration, as well as our adverse effects that we see. And now I'd like to pass it off to Dr. Rao, who will talk about our recently published paper and the side effects, the cardiac side effects of targeted oral oncolytics.
Thank you, Dave, for that excellent summary and setting the stage for our further discussion today. Really an exciting time with respect to precision medicine and molecular targeted therapies for our oncology patients. And I'd like to start this part of the talk with this cartoon, and it really kind of is emblematic of what the FDA really is up against. You have them, you can see in this cartoon, the FDA is the lifeguard, and what does a lifeguard do? The lifeguard is, always looking over his shoulder, making sure that no one's drowning, right? That's sort of part of the role. But in the sense, the pharmaceutical industry is coming to the FDA, almost, weekly with new therapies, many of which are molecular targeted therapies. And, the FDA is tasked with approving, many of these life-saving therapies at fairly breakneck speed. I mean, we're talking about trials that sometimes will have a duration of about 3 months. There is a dramatic improvement in survival, and the FDA is tasked with saying to the community that, hey, we need to get this out there because this is better than standard of care, and we need to be able to provide this for our patients. But the flip side of that is that in approving medications at breakneck speed, what ends up happening is that many of these therapies have not been in the community for very long. And so therefore, we really don't know what the extent of side effect profiles might be beyond just those first few months. And that's really where we're going to spend a little bit of time talking about what we've learned about many of these amazing therapies, but potentially some of the cardiac side effects from that. Next slide. So this is I love this figure. This is a diagram. It's called a human kinome. And Dave has already spoken to you about the mechanism of action of many of the targeted kinases. And what they work on is on kinases, as he mentioned. And this is a figure that puts the kinases into families based on sequence homology. And you can see that it's really quite elegant. And there are different families of kinases that you can see in this figure. Next slide. Now, what is, as we talk about molecular targeted therapies, Dave mentioned that we can tumor type and specifically identify mutations in specific proteins or kinases. Now, what I was always struck by this figure, and when we talk about precision medicine, you think about targeting a specific, very specific kinase. Now, this is a figure demonstrating that same kinome map, and what these red balls signify is an affinity for a kinase. And these are different compounds that have been studied for malignancies. And look, for example, at the bottom there, you can look at the bottom right, sunitinib, which is an FDA-approved drug used quite commonly for multiple malignancies. And what is just mind-blowing, honestly, is that you can see that the red balls are almost across every single family of kinases that are out there. What this is telling you is that the drug, while it may be great at targeting a specific target tyrosine kinase, you can see that it actually has affinity for many different kinases. And what does that sort of make you think about? It makes you think that, well, there could be some off-target toxicities because these kinases are used throughout the body for normal physiologic function. And so this sort of, was very eye-opening for me, and I think has really kind of informed our community about the potential for off-treatment side effects. Next slide. So specifically focusing on the cardiac impact of oral targeted therapies, there are three real main areas where we've seen some of this off-treatment side effects. One is with regard to the EKG and something called QT prolongation. The second, you can see the number of drugs there that are listed that can have an impact on the QT interval. The second group is hypertension, which is something quite commonly seen, and you can see a list of medications there. And then lastly, on the far right there, you can see heart failure, or LV dysfunction that can result in heart failure or symptoms of shortness of breath and edema. And there's a list of medications there. Next slide. So in our paper, what we ended up doing, this is sort of the methodology for why we came up with this. Given the number of drugs, oral targeted therapies, and as of July of 2020, there were 85 FDA-approved oral molecular targeted therapies. And what we did was look at the labels of these medications, which is, the FDA label is really one of the most comprehensive areas to look for side effects, because they're looking at all of the phases of trials, and the investigators will report side effects, and that is compiled by the FDA and the sponsor and placed in their label. And so what we did was we looked at all of these oral molecular targeted therapies, and you can see there are 56 out of 85 that were FDA approved at that time. 66%, or 2/3, actually recommended some form of cardiac monitoring. And that is because of what I had just shown you, that there can be QT prolongation, hypertension, and LV dysfunction. So what we did was we took the data from the FDA labels, as well as the phase 3 trials when data were not available from the label. And what we formulated what we thought were reasonable monitoring recommendations for these patients. And the most important point of this slide is the third bullet point there, which is really what we're trying to do is we're trying to balance the risk of over-testing, which may lead to inappropriate withholding of life-saving antineoplastic therapy, with missing the CV toxicity, which may impact the outcome for our patients with malignancy. So it's that fine balance of doing enough so that you capture these events, but not over-testing so that we're not inappropriately stopping life-saving therapies. Next slide. So this was the paper that we just had published in the Journal of American College of Cardiology, the June 1st issue. There's the reference there for you. And I think what's most important about this slide is the list of authors. And this really speaks to the concept that cardio-oncology really is a multidisciplinary effort. And what you can see from the authors there, as you can see, Dr. Reeves there is our pharmacist collaborator. We have a number of cardiologists, Dr. Chugg, Dr. O'Quinn. Michael Fradley is actually an electrophysiologist. Anna Barak and Dan Lenahan, both cardiologists. And we also had oncologists, Meghana Raghavendra and Susan Dent. So we really wanted to have a broad representation of a cardio-oncology community weighing in on this important issue about what we call here the clinical approach to cardiovascular toxicity of these agents. Next slide. This is just an example of one of the concepts in the paper. This is specifically looking at LV function monitoring. And this is just to give you an example. We won't go into all the details of all the drugs. It would absolutely make your head spin. But it is a resource for you to refer to. But this is the kind of information that's involved in this paper that you can see. We break it down on the far left there by the actual tyrosine kinase. So these are the groups or categories. We have the drug names there. And then on the far right, you can see the actual recommendations for baseline monitoring, as well as how often one might want to consider LVEF subsequent monitoring. And this is sort of our table 2 with our recommendations for monitoring. Table 1, which is not displayed here, has all of these different medications grouped by, again, drug target. It has dosing, and it has the actual specific toxicities, as well as incidences of these different toxicities grouped by low incidence and on up. Next slide. So let's focus a little bit here on LV dysfunction and what can then lead to congestive heart failure. In the cardio-oncology community, we use this term CTRCD, and what that stands for is cancer therapy-related cardiac dysfunction. So how do we define that? Well, it's really a decline in LV ejection fraction of greater than 10% and or a value of less than 53%. Now, what is an ejection fraction? On the right there, you can see an echocardiogram. That's a 4-chamber view. And you can nicely see labeled there, the LV stands for left ventricle, LA for left atrium, RA for right atrium, and RV for right ventricle. And what we're specifically looking at is the LV in terms of ejection fraction. So that is basically what is the amount of blood ejected with each beat from the heart. And really, normal sort of range of ejection fractions, you look at a range of about 5% on an echocardiogram. It's typically above 50% would be considered normal, and below that would be abnormal. And what's nice about the echocardiogram as well is there's no radiation exposure to the patient. You also have the ability to look at valvular disease, which can be affected by radiation, for example, that patients get in cardio-oncology. And you also get a really good look at pericardial effusions, which is not uncommon either due to the treatment and or the malignancy. Next slide. So there's one additional aspect to cardio-oncology echoes. There's something called myocardial strain. And it's just important to realize that the part pump is not just a simple pump. It's not just ejecting blood, but the way it actually works is that it twists and torques every time it contracts. And that is a term called torsion, and that can actually be measured using simple techniques that can be obtained with most echocardiogram software and vendors. And what it does is it actually can pick up LV dysfunction prior to drops in ejection fraction. And there have been multiple papers published in this area in cardio-oncology. I just list a few here. You can see that a 10 to 15% drop in what's called global longitudinal strain can actually predict a future drop in ejection fraction, both with anthracyclines and trastuzumab, which we've talked about earlier, and there's a reference for you. Now, why is that important? It's important because we're in prevention mode, right? We want to catch these things before you start to see damage. And if you can catch them early, there's this thought that you can actually either hold the medication in the case of trastuzumab or start cardioprotective medications. There's an additional study that showed that global longitudinal strain has incremental prognostic information in oncology patients when combined with clinical variables. And there have been recent studies. There was a recent study called the SECORE study, which was published in JACC. You can see the reference there, that was looking at trying to utilize strain analysis to guide management for patients. The trial, was well done, and unfortunately didn't really show dramatic changes in outcomes for patients, but more is certainly needed to study this. But nevertheless, myocardial strain has played a role in cardio-oncology, particularly to identify early these LV dysfunction patients. Next slide. So if this is an important piece, is that cardiac MRI actually represents the gold standard for measurement of LV ejection fraction. Why is that? Because it's not limited by geometric assumptions that you are with ultrasound. It's a three-dimensional representation of the left ventricle. And there are consensus statements and other papers that have recently been published looking at cardiac MRI in the cardio-oncology sphere. Important for this audience is just to remember that if we're really going to consider stopping an antineoplastic agent, and again, our goal with cardio-oncology is not to stop anything. We want the patient to receive their life-saving therapy. But if, for example, there has been a drop in ejection fraction or a borderline, ultrasound can be limited by windows. And so sometimes you really don't get a good look and get a good assessment of ejection fraction. That it's recommended that we pursue a cardiac MRI before withholding life-saving therapy to really get a better sense of what the actual ejection fraction is. And this will actually give you a number. It's not a range. It'll say the ejection fraction is 56%, for example, and very accurate. Next slide. So here's just a figure from our paper that really is an algorithm, a guide for LV dysfunction monitoring and management. You can see at the top that if you're on an oral agent with the potential for LV dysfunction, which is listed in the paper, it's the first step always is to assess and optimize baseline cardiovascular risk factors. What does that mean? Well, that's looking at things like making sure their blood pressure is well controlled. If the patient's diabetic, make sure their sugars are well controlled. A number of things like that that we do quite routinely in cardiovascular care for primary prevention is to make sure that the patient's optimized going into therapy. Next is to get an assessment of their baseline ejection fraction. That's using the best available tool at your institution. Typically, that's two-dimensional echocardiography that I showed you an image of with or without strain. There's also three-dimensional echocardiography, which has a little bit, have some advantages to 2D, but unfortunately is not widely available. Then it would be to review Table 1 for the monitoring recommendations from our paper. Again, consider cardiac MRI if the baseline ejection fraction is abnormal or you can't really see very well to get an accurate assessment. And if the ejection fraction is normal at baseline, go ahead and start your agent. Now, if there was an abnormal, you can see on the far left there, if there's an abnormality at baseline, we do recommend having a discussion with oncology and potentially referring to a cardio-oncologist to figure out what next steps might be. Now, if you go back to the algorithm, if the patient's baseline study is normal, you initiate the agent. Now, in monitoring, you monitor for signs and symptoms of congestive heart failure. So new lower extremity edema, new shortness of breath. Fatigue is a difficult one because so many patients with cancer have fatigue, but that can be also a sign of heart failure. So if there are new symptoms that make you think that the patient might have heart failure, we recommend a repeat imaging study. And if the LV function has dropped below 50%, very important for the cardiologist or cardio-oncologist to compare images. There can be quite a bit of variability in terms of reading of transthoracic echocardiograms. And so therefore, very important to look at the study side by side. Consider a cardiac MRI if you really think there might be some equipoise in terms of what really is going on. Then it's to consider other causes if there's LV dysfunction. Could the patient have ischemia or coronary disease that might need to be addressed? Could the patient have a tachycardia that's, a new onset AFib, for example, that's been going fast that might lead to LV dysfunction? And it might be important at that point to temporarily hold the agent and try to assess the patient, treat the potential contributing factors, consider initiation of some cardioprotective therapies, for example, ACE inhibitors, angiotensin receptor blockers, or beta blockers, and consider referral to cardio-oncology. And of course, always this multidisciplinary open lines of communication between the cardiologist, the oncologist, the pharmacist. Everyone really needs to be on the same page here because we do not want to delay life-saving therapy. And so it really requires a coordinated effort, and that's where really cardio-oncology programs are coming into play. Next slide. This is just an example of that same algorithm, but actually having a patient case or scenario. And I'll just take you through it quite quickly. 68-year-old man with metastatic EGFR positive non-small cell lung cancer who was started on osimertinib, which is one of the oral targeted agents, has a past medical history of hypertension and prediabetes. He had lisinopril added for a systolic blood pressure of 150. He also had an elevated cholesterol with an LDL of 150 and had rosuvastatin started. So he gets his baseline echocardiogram as would be recommended given osimertinib's potential for cardiotoxicity. His global longitudinal strain there is normal and his ejection fraction again is above 53%, so normal. And therefore, the patient has the drug started. So 2 months after starting, you can see in the red, he starts complaining of some shortness of breath, which is new in onset and unexplained by any other mechanism. A two-dimensional echocardiogram was ordered, and now his ejection fraction has dropped to 45%. So remember that it's a greater than 10% drop in ejection fraction. He's gone from 63 down to 45, and he's also had a drop in his global longitudinal strain. So therefore, there really does appear to be something going on here that's not subtle, likely in this case not needing a cardiac MRI. So his ejection fractions were compared, and given this new drop, an ischemic evaluation was undertaken, which was negative for any degree of ischemia. His blood pressure was well controlled. He had a couple of blood tests like a thyroid that was checked, and his agent was held at that point, the osimertinib, and there was a discussion with the oncology team. Given his drop in LV function, he had cardioprotective medication added, which was carvedilol, in addition to his ACE inhibitor, and a cardio-oncology consultation was obtained. 6 weeks later on therapy, cardioprotective therapy, remember he's been off of osimertinib, his ejection fraction does improve. It's gone from 45% up to 49%. And again, at this point, there's a discussion between the oncologist and the cardiologist. Are there other options for this patient that would be reasonable? If not, in many cases, there are not good alternatives. You plow forward with the current therapy and monitor the patient closely. So that gives you a sense of what this might look in practice. Next slide. So this is a clinical pearls section from the paper, which kind of summarizes what we just talked about. I think I won't get into too many of the details here because we've really kind of covered this, and you can see more about this in the paper. Next slide. So let's move on to QT prolongation. This is just a summary letting you know that oral targeted therapies have a risk of QT prolongation on the order of 0 to 5.2%. Why do we care about it? Well, it's a rare complication, but we all have been trained to be aware of something called torsade de pointes, which is a polymorphic ventricular tachycardia that can occur in the setting of QT prolongation, which can be fatal. And that is why there's been such an emphasis from the FDA and putting these on labels that many of these agents can prolong the QT and need to be monitored. So what are some of the risk factors for QT prolongation? You know, the biggest one I want this audience to be aware of are electrolyte disturbances. Many of these patients, as you are well aware, have nausea, vomiting, diarrhea that can occur with many of the oncology therapies and can therefore develop hypokalemia, hypomagnesemia, both of which can predispose a patient to QT prolongation and subsequent arrhythmias. So some strategies on the right there, you can see avoiding other QT prolonging drugs, and I'll show you a list of some of the common offenders. A big thing to remember is if you see a QT that's greater than 500 milliseconds, that's sort of a magic number. You need to, your eyes need to perk up and go, okay, something could be going on here. We need to be very careful. There are some recommendations regarding changes in the QT, which is in terms of milliseconds. Greater than 60 milliseconds is something you often see as something you need to watch out for. Maintaining electrolytes at a good level, as Dave has mentioned earlier, watching for drug interactions, watching out for patients with kidney dysfunction. There are agents that, you know, particularly if you're on multiple agents that can prolong the QT, for example. Next slide. So this is an algorithm that we put together that's in the paper that really gives you a sense of what it would look like in practice. So you have a baseline on the far left there. If there's a QT that's greater than 600 milliseconds from baseline, you move forward. Now, the key normal values for a male and female are different. For females, it's a QTc greater than 480 milliseconds. For males, it's greater than 470. If that occurs, you know, neither of those are there, you move on and proceed with therapy. And then if you move to the right, if you do have some of those abnormalities, it's recommended that you manually measure the QT. There's a specific formula called the Friederichia formula, which is probably out of the context of this talk, but if you read the paper there, it kind of describes how you would do that. If the QT continues to be prolonged, next step would be to correct for electrolyte abnormalities and arrhythmias, and you can see that there. And then lastly, eliminate other QT prolonging meds. And if the QT remains prolonged after all of those different things, consider an alternative therapy. Next slide. Here's kind of a gold table. So these are the drugs to avoid, if possible, in patients taking antineoplastic agents with the potential for QT prolongation. And there's a long list here, but I think the ones that I'd want you to focus on are, you know, obviously antibiotics are a big offender, and patients will have sinusitis, they'll have cellulitis, they'll have pneumonia, they'll have so many different infections, as many of them are immune compromised. And very important to recognize when you start these therapies that they can impact the QT. The second column are the antiemetics. You'll see one of the big offenders there is ondansetron or Zofran, given very commonly to oncology patients. So be very cautious of that, and particularly in patients on any of these agents that can prolong the QT. Depression obviously goes along with a lot of the diagnoses, both in the cardiology sphere, but also in the oncology sphere. Many of these patients are on tricyclic antidepressants or SSRIs. Very important to be careful in that setting. And you can see some of the others there. Next slide. So these are the clinical pearls for QT prolongation. I mentioned the Friederichia formula, which you can see in the paper. It's important to recognize that the risk of torsade is low. We spent a lot of time focused on QT, you know, for a very rare event. And so again, it's that whole concept of balancing the risk of over-testing and stopping life-saving therapy versus, you know, what are the potential cardiac toxicities. This is a rare event, but, you know, a fatal one that, you know, that's why it's received so much attention. You know, there's some barriers to the monitoring of QT because of the definitions of QT. Another point I think is important for this audience is tachycardia. You will see tachycardia very frequently in the infusion clinic, and even just in the clinic when a patient shows up for the oncology clinic. Much of this is sinus tachycardia due to dehydration, but not always. And so very important to get an EKG in that patient with tachycardia, because it might be something else, such as an SVT, or which is very common, atrial fibrillation. in the population that's receiving these, particularly with elderly patients. And it would change management in terms of stroke risk and blood thinners, etc. And then lastly, AFib and VT can be seen specifically in our arrhythmic complications of ibrutinib, which is a oral agent that you will see used quite commonly for a number of different malignancies. And it's quite challenging to manage those patients. Next slide. And this is just one slide kind of addressing some of that challenging aspect with regard to ibrutinib. There are de novo, so new onset atrial fibrillations that have been directly linked causal from ibrutinib. And we see this in practice almost weekly. Now it's challenging because AFib is often very symptomatic for a patient. They get a rapid heartbeat, they're short of breath. So it's very important either to get the patient out of AFib with like a cardioversion or an antiarrhythmic drug, or rate control the patient, and then anticoagulation. These are the things we face quite commonly. So why is it challenging in this population? It's challenging because ibrutinib has, as Dave mentioned earlier, has lots of drug-drug interactions through the cytochrome P450 as well as P-glycoprotein system. And we created this table on the far right there. The ones in yellow are actually ones that don't have drug-drug interactions that are significant. And you can see the ones that are not in yellow do. And you'll recognize many of the drugs over there, diltiazem, verapamil, digoxin, all with significant interactions, which are rate controlling agents. You can see many of the other agents that we use for rhythm control, amiodarone, Multec or dronedarone, dofetilide, interactions. And then lastly, blood thinners. Ibrutinib itself is a very potent, it has impacts on bleeding, clearly been shown in the oncology trials. And that's been pretty well worked out that a lot of this has to do with platelet dysfunction, which can affect glycoprotein signaling. It also affects platelet adhesion to collagen. So really antiplatelet agents it's important to consider discontinuation in patients on ibrutinib. But it also begs the question of how do we anticoagulate these patients? Many of them have a high stroke risk or thrombotic risk, but they're also at significant risk of bleeding. And several recent publications have kind of nicely outlined some of the strategies, but really there's more data that's needed in this area. It's quite complicated. Next slide. Let's move next to hypertension. So this is something everyone sees every day. Hypertension is extremely common in the population, irrespective of any molecular targeted therapy. So these are some of the proposed mechanisms of actual oral molecular targeted therapies, multiple mechanisms affecting the vasculature with nitric oxide production, endothelin, as well as decreased natriuresis at the kidney. This is kind of well described in our paper. Next slide. So how do we define high blood pressure? This is important because, again, we're using FDA labels. FDA labels look at phase 1 through 3 clinical trials and summarize that. And so when a patient is in a trial, the investigator has to comment on whether there's an adverse event with hypertension. And they sort of grade these. You can see here by 1 up to 5, 1 being just a minimal increase in blood pressure, all the way up to 5 where the hypertension is thought to have led to death of the patient. So this is how, these are the criteria that we use. What are some of the risk factors? Obviously, some of the pre-existing hypertension, older age, greater than 60, and obesity, or really even going down to a BMI less than 25, which is in the overweight category, is still a risk factor for hypertension. Next slide. This is looking specifically at the oral agents. There's a list here of the molecular targeted therapies, and these are the grades that you can see that I just mentioned to you. And some of these really pop out. Odds ratios, for example, of sunitinib. Interestingly, that was the one, if you remember, I showed you on the kinome map that had red balls all over the place. You can see that the 22.72 odds of having significant hypertension with sunitinib. And really, it depends on the agent. Some are much bigger offenders than others, but you can see this whole list are offenders. And this can be up to 60% of these patients who receive these agents. So more than half will develop significant hypertension. And so extremely important to be aware of that and be ready to manage it. Next slide. This was an algorithm that we created that's in our paper. Really, you might ask the question, well, what's the blood pressure target that we should be focusing on? And really, we're really looking at less than 130 over 80 millimeters of mercury in the clinic. And we base this algorithm on ejection fraction because if a patient has LV dysfunction, there are specific therapies that you need to think about to treat the hypertension. If you go down the right side of the pathway, if the ejection fraction is less than 53%, and we really focus on this concept of without heart failure, because if you have signs or symptoms of heart failure, there are other specific therapies you may want to consider. But if there's asymptomatic LV dysfunction, we really focus on angiotensin receptor blockers and beta blockers such as carvedilol specifically, and then titrating, and you can just follow the pathway down there. On the left-hand side, you can see if there's a normal ejection fraction and they're hypertensive. We really, again, focus on angiotensin receptor blockers and dihydropyridine calcium channel blockers like amlodipine or nifedipine. And if the patient's not at goal, continue to titrate, and you can see a couple of key points down there. Do not forget about sleep studies in your obese patients. It is a large driver of hypertension, and fatigue, which patients will thank you heartily if they actually get energy back during their treatment when their sleep apnea is actually treated and they're getting oxygen when they're sleeping. Next slide. This is a patient scenario looking at patients with, you can kind of, just for sake of time, we'll keep moving through, but this is in the paper. This is just a way to manage a patient who had hypertension, which is really kind of what we describe in using agents. Next slide.
So Vijay, this is Dan. Okay. Great job, of course. This is really a master class review, which as you know, you had gotten that feedback from some of our colleagues. But one thing I would emphasize, and it wasn't emphasized in this review, I think it was mentioned, but especially in people whose blood pressure is not at control, or they're still having difficulty with optimal blood pressure control, is to really emphasize, asking about non-steroidals, because those are a frequent offender that's not listed on their medication list.
No, that's a great point. Thanks, Dan. Yeah, non-steroidals, one of the most commonly taken over-the-counter medication by patients that we don't ask patients about, right? So it's a great point to ask patients about, and Dave mentioned this earlier about herbals and supplements and things like that, but non-steroidals is a great point. Ask your patients, minimize the use of non-steroidals. So thank you for that. Just a summary here of the hypertension. Remember that there's a very high incidence of white coat hypertension, which actually has been demonstrated in the literature to be higher in the oncology population. And so very important to think about home blood pressure monitoring in patients. And you can read the rest of those there, and for the sake of time, we'll move on. I want to leave some time for some questions. Next slide. This is a really interesting point here. I'm not going to go through all the details of this slide. You can see this in the paper, and those of you who want the slides, but the actual measurement of blood pressure is critical, because again, we're potentially stopping life-saving therapy. We're treating numbers, and those numbers need to be accurate. And it's just fascinating that I'll just take one example of things that if you don't do this properly, you're going to get erroneous readings. So for example, look at the first bullet point. If the patient's sitting with, if they're not relaxed, sitting in a chair with their feet on the floor for more than 5 minutes, you can actually have a greater than 10 to 20 millimeter increase in blood pressure. Look at the second. If the legs are crossed when you're measuring the blood pressure, on average, you can have a 5 to 8 millimeter increase in blood pressure. It's fascinating. And frankly, we do a very poor job of measuring blood pressure in our own cardiology clinics. And so this is you can go through these, but it's important to really take some time and look at this and do it properly. Okay, next slide. So summarizing, this was our central illustration, putting it all together. Oral antineoplastic with the potential for CV toxicity, do a baseline CV risk assessment, Those are things like looking at blood pressure, cholesterol, make sure they're not diabetic, etc. The three main areas that we focused on here were QT prolongation and arrhythmias, LV dysfunction and heart failure, and hypertension. The monitoring, remember for QT that it's the EKG. Consider there are newer methods like Holters and wearable devices actually now that are able to measure QT in the outpatient setting, and certainly looking for arrhythmias. We talked about the imaging modalities, and then home blood pressure monitoring and ambulatory blood pressure monitoring can be useful. And then lastly, how do you manage them, particularly for electrolytes and QT prolonging, avoiding of medications, for LV dysfunction, ruling out other causes, starting appropriate therapies, and hypertension, we talked a bit about the specific agents that you may want to consider. Next slide. So with that, this is our Franciscan Health Cardio-Oncology team. You see Dr. Chug there, who wrote a fantastic hypertension section for this paper, and some of the others there. You can see our emails there. If you have any questions about what we've talked about today, we'd be happy to address those. And with that, we'll open it up for questions. We have, as Dave mentioned, Holly Page, who's one of our fantastic nurse navigators who really has taken the helm with respect to oral targeted therapies. She has been setting and following many of these patients. So we have her on board as well if you have questions for her and Dave as well. So with that, we thank you for your time, and let's open it up for questions.
I have a question. This is Agnes, Bari, Italy. Congratulations for your masterclass speech for both of you. My question is for Dr. Rao. What about the SOCUR trial? Can you tell some more words? Because I would like to know if I perform an echocardio and I find a drop of 15% of GLS with a normal ejection fraction, what should I do? Should I add ACE inhibitors and beta blockers and increase the frequency of cardio-oncological surveillance, or what else should I do? Thank you.
Yeah, no, that's a fantastic question, and it's one we face all the time in clinical practice. And the SOCUR trial, really, for those of you who are not familiar, was looking at a GLS guided management strategy versus non-GLS, and to try to see if you have drops in GLS, and you initiate cardioprotective therapies, for example, beta blockers and ACE inhibitors, would you subsequently have an impact? Now, most of the patients in that study were receiving anthracyclines or Herceptin, so this was not a oral molecular targeted therapy population, but it does try to get at that question, the specific question you're asking. And it did not really show, I think there've been multiple viewpoints on this, and I'd be happy to hear what Dan also has to think about this, Lenihan. But from the perspective of making an impact at 6 months in terms of hard outcomes, there were no significant hard outcome differences between the groups. So, based on that, which was the largest, such study to sort of address this, I think we don't have the evidence yet from that specific study. Now, what do I do in clinical practice? I still know that, and based on some of the prior studies, that drops in GLS can predict patients who can have drops in LV dysfunction in the future. So, clinically, to me, it's always a risk-benefit analysis, right? So, if what's the downside to starting a patient on a beta blocker and/or ACE inhibitor or angiotensin receptor blocker? Obviously, hypotension, if you have a patient with blood pressures running in the 80s to 90s, likely not a good idea. However, many of these patients still have hypertension and, frankly, tolerate fairly low doses of beta blockers like 3.125 BID of Coreg and/or 2.5 milligrams of an ACE inhibitor. Do I have the data to support that? Probably not with from the literature, but do I do it in practice? Absolutely. And it's, I think you have to individualize it, at least I do with each patient, and sort of say, look, what's the risk benefit here? If the benefit is preventing a future drop in heart function or stopping of a medication or the development of heart failure, which as a heart failure cardiologist, I'm in the business of doing. I want to prevent all of that in prevention mode. to me, it makes sense to move forward with that and treat that particular patient that you mentioned. I would not stop the chemotherapy, certainly not. But monitoring them more closely would mean, potentially, as opposed to a Q3-month echo, maybe I would get an echo in a month on therapy to see that there's been any drop in function. But I think you really have to individualize it with the specific drug and the patient. But that would be my take on it. Dan, do you have any other thoughts?
Oh, well, Vijay, of course, I would, but and then I would add thanks to Dr. Fioretti for the question, because I think it's a prominent question on people's mind. But I would argue with a few points, not to say that you were wrong in any way, Vijay, but rather that I think that if you look beyond the surface, then I would say we very much have evidence that that approach is effective. So for example, if we say, well, let's look at the Succor study, and you're right, the strain-guided approach didn't show a difference in ejection fraction as a continuous variable, meaning, we didn't see a clearly documented change in the patients that were in that study. However, generally it was a very small study when you compare to very large studies that we do for other things, like, heart failure studies where we're looking at 1,000 or 5,000 patients. So they were looking at a much smaller population, and they were able to detect a difference in two major points in those that they used a strain-guided strategy. One was, if you looked at a threshold of EF change, not a continuous variable, but meaning, was there a greater than 10% change? And in the group that used a strain-guided approach, there was a reduction in the threshold of cardiotoxicity. And then also those patients were more likely to be on cardioprotective therapy based on the strain-guided approach. So you could look at it from the way that you said, but I would also say you could look at it from a point of view of, if I am preventing the development of heart failure, that was the goal. That was what we were trying to do. And they did show that. And then the other piece is go back to a trial called Stop HF. And it was done in Ireland, and they used biomarkers, and they had a very narrow range. So if a BNP was greater than 50, it was considered early evidence of heart failure. This is not a cancer population. But what they showed is that if you used a BNP guided approach in a general population, that you could reduce the development of heart failure using the BNP as a guide. So all I'm saying is that you do have evidence that if you use a more sensitive guide, that you will prevent the development of heart failure. And that, like you just said, that is what we are trying to do. So I would argue very differently about the Succor study, what the findings were there. And I think that in a patient that Dr. Fioretti brought up, a patient you're seeing in clinic, you see a change in strain that's new, that's worsened. I would absolutely act on it by increasing cardioprotective therapy, for sure. You have to decide what's the best cardioprotective therapy in that instance.
Yeah, no, that's great, Dan. I knew you would have a perspective on this, and I appreciate that, definitely.
I have 3 questions. Yeah, one is on adherence. How do you monitor adherence to these oral targeted therapies because they're staying at home? And 2 is on the monitoring cardiovascular adverse effects. For patients, for example, like ibrutinib, you talk about it, you talk about sunitinib, the QT prolongation and atrial fibrillation, given that they're given orally at home, how often do you see these patients in the clinic to monitor for these adverse cardiotoxic effects? And 3 is on multidisciplinary collaboration. Yeah, you have emphasized, and I believe in that, the importance of multidisciplinary approach in the management of these cardio-oncology patients. I'm just wondering, I'm curious about the role of the nurse in your clinic, because in that paper, how come the nurse is not included in the authorship?
I can take the first question.
Dave, take the first one.
On how to monitor the adherence to these patients. So in clinic, we have a dedicated pharmacist who follows up on our patients, calling them, making sure that they're getting the medication first off, because a lot of them have to get them via mail order from these limited distribution channels, and then making sure that they're taking them, checking up to see if they're having adverse effects, so that we can provide the appropriate supportive care, so that we can maximize their tolerance and make sure that they keep taking the medication, things like mucositis and those type of nausea. We're making sure that we're maximizing our management of those. So that's largely driven in the cardio and in the oncology clinic by our pharmacy program. I know that other clinics utilize nurses in that fashion as well. And our nurses do play a large role in making sure that patients are tolerating their therapy, but the pharmacist is the one who's driving that. As far as patients coming back and monitoring, that's probably one of the areas that our nurses within the cardio-oncology play the largest role. And I guess we can let Holly take that and describe kind of where she comes in and really ensuring that our patients are being monitored appropriately and coming in at the appropriate intervals, and really following our patients.
Yeah, and I would just add, and I agree, I think the monitoring piece is unique to every institution. I think we still have a long way to go. We put these sort of guidelines out there, or a practical approach to these specific agents. But in terms of the utilization of, we really focus on the patient having, for example, hypertension with sunitinib, monitoring their blood pressure at home. As you point out, they're not coming to the clinic that often, and Dave can maybe point to that, but it depends on the agent and it depends on the oncologist, frankly. So, how often they come, and that was something even when we were writing this paper. The point was, in terms of being assessed when they are, we couldn't sort of give a predefined time point, because every patient is going to have a different return to the office. And so the point being that when they are seen in the office, and though I would argue, and Dave probably knows this better than I do, how often they come back to the oncology clinic, it's a lot more frequent than they would, for example, to the cardiology clinic. Though, when I see patients with heart failure, they're coming back almost monthly for some of my advanced heart failure patients. And I think some of the oncology patients also get seen quite frequently. And so the concept is, when they are seen in clinic, to be able to follow the blood pressures and to follow and make sure that they're doing them at home, because even if they're seen every 2 to 3 months, there's quite a bit of time in between visits where blood pressures can shoot up to the 180s and 190s, and we wouldn't know about that. So, we're still in the process, and Holly can speak to this, we're in the process of working on the protocols and the algorithms to really try to standardize this a little bit more for our patients, because we don't want to have one approach in one area and just be really deficient for a whole nother area. So, for example, all of these agents that cause hypertension, I think it's important to start off with a plan that you're going to be doing following this patient, and then stick to it. And I would say that we're still in the process of kind of building those out. Holly, if you want to speak more to that.
Yes, so I will go and I try to meet the patients in the oncology office, or I will call them at home and introduce myself and my role, and then I will explain whatever, like oral chemotherapy they're on, what kind of tests that are needed to be done up front, and then also how often they need to be repeated, because I have some patients that need echoes every 2 months, and I have some that need every 3 months. And kind of back with the hypertension, if they're already on antihypertensive meds, I tell them not to be surprised, but their pressure may even go up and that their meds may need to be adjusted. And then also the ones that don't have high blood pressure, me and also Mina, our pharmacists in the clinic, warn them up front that one of the most common side effects would be hypertension. And I just kind of keep track as far as like EKGs and all. I just keep track of their office appointments and what days EKGs need to be repeated. And we have a great tool in our Epic system for our navigators, and that kind of lets me know. I just plug it in after I get the appointments for the patients, and I'm able to plug it in. It's kind of like my to-do list for that day. So that helps me keep track and keeps me sane.
Yeah, and then
Thank
sort
you.
of the third question, I think, just with regard to the authorship on the particular manuscript, I would say two things. One is we are definitely multidisciplinary. We definitely, advocate for our nurse navigators. I think we've had publications as well as presentations at GCOS and ACC Cardio-Onc meetings. In fact, Holly was the first author on a award-winning programmatic approach at the ACC meeting. So we are excited about that. In fact, there's an upcoming paper that we're looking at working on specifically with our navigators, looking at the role of the nurse navigator in cardio-oncology. So that is another manuscript forthcoming. With regard to this particular paper, I will just tell you it was a labor of love. Took probably a year to put together with authors from all over the place, and was really, really tough to make happen. So, I think, we did the best we could, and I think we're going to continue to engage our nurse navigators and put them in prominent roles to present and sort of lead this field, which is, again, we're excited about that. That's kind of
yeah. So, Vijay, thank you for just a fantastic presentation, and Dave and Holly, really appreciate all of your leadership really in this whole area. And this was a fantastic presentation and really a great publication. We have now gone over time, so I will we'll throw the flag at this point and let everybody out. But nonetheless, thank you guys so much, and we really value your leadership, and you're welcome back anytime.
Thank you so much for the opportunity, everyone. Have a great day.
Yeah.
Thank you
all.
Goodbye.
Thank you. Goodbye.
Goodbye.